and welcome to today's CellTalk. In today's session, Numer will deliver the talk on Poziotinib for patients with HER2 exon 20 mutant non-small cell lung cancer, results from a phase 2 trial. Our speaker Numer is a clinical content writer at Renix. He is responsible for writing scientific medical white papers and blogs. His work is centered around making complex scientific concepts accessible to lay people. He is currently pursuing a PharmD at Lahore University. His writing at Renix focuses on precision medicine for cancer patients. Numer is currently working on gene map projects and delivering scientific content that aims to provide gene-centric information for various diseases and their treatments. Renix has allowed him to gain leadership in various projects related to content. Now I will invite Numer to lead the session.
Thank you, Yogita, for the kind introduction. My presentation today is about a clinical trial that is aiming to target the HER2 mutated non-small cell lung cancer using the new drug called Poziotinib. The paper that I am presenting is titled as Poziotinib for patients with HER2 exon 20 mutant non-small cell lung cancer, results from a phase 2 trial. It is originally authored by Elamin and others. It was published in the Journal of Clinical Oncology, and the year of publication is 2021, and it has impact on the HER2 mutated non-small cell lung cancer. So starting with the introduction, lung cancer, as we all know, it's a type of cancer that brings in the lungs when the cells in the lungs start growing uncontrollably. Then it causes the lung cancer. It is the most common cause of cancer-related deaths worldwide. And within lung cancer, there are subtypes. The most common one is the non-small cell lung cancer. Within non-small cell lung cancer, there can be further subtypes, but overall, it accounts for the majority, about 80% of the cases. So for the general background, I just want to talk about the HER2 or the HER2 mutations and the new drug or the Poziotinib drug. And that is the main aim of this clinical trial. These HER2 mutations, they are found in 3% of the non-small cell lung cancers. And out of these patients having HER2 mutations in lung cancer, approximately 48% or half of the patients have insertion mutations in the exon 20. So you can see on your right side of the screen that a normal cell has HER2 receptors, but once there is a mutation, the number of receptors is increased and the cell starts going more than the body needs it to divide. And then the Poziotinib, that is the actual therapy or the new drug that is being evaluated in this clinical trial. It is an orally available targeted therapy. It's an irreversible covalent TKI or the tyrosine kinase inhibitor. It's a type of targeted therapies. It has performed well in the in vitro and in vivo models, and that's why this clinical trial is being performed. Now, the present challenges within the HER2 exon 20 mutations are that these mutations are resistant to some of the TKIs that are already approved, and it is difficult to tackle. You can see that this concept is being illustrated by a sort of chess game between the healthcare providers and the mutant mass. Whatever we have came up so far for this mutation, it has found ways to resist those ways. So this is a sort of chess game, and currently our options are very limited for this patient population, and there is a substantial need for new options. And in this, the objectives of the research come in. They are providing in this clinical trial a new option to target these sort of mutations, and that new option is Poziotinib. It is the clinical trial will assess the efficacy as well as safety of Poziotinib in the patients having HER2 mutations or the insertion mutations in the exon 20 of the HER2 in non-small cell lung cancer. So moving on to the methodology, the study design, it's a single center open label phase 2 clinical trial. Uh, as you can see, the center, it's not a very large sample set, and the diversity is not very good. They are only taking the patients from one center only. And another important thing to notice here that it does not have any control arm. Only the one open label arm is there, like one intervention arm is there. There is no placebo arm or the control groups. And there are some other cohorts of this clinical trial. They are not they won't be discussed in this presentation, and they're not the center of this paper upon which I'm basing my presentation. But it is still important to know that there are some other cohorts of this clinical trial, and they were targeting some other mutations like the exon 20 mutations in the EGFR and some other mutations in the same gene. Within the study population, there are some key eligibility criteria. First thing, the most obvious thing is that all of the patients they recruited, they were from stage 4 or the recurrent HER2 mutated non-small cell lung cancer. After that, the eligibility criteria were that the patients have to be at least 18 years old. They should have documented mutations in the HER2 exon 20, and those mutations were documented by gene panel tests that were commercially available, like the Oncomin comprehensive assay, Cordant 360 assay, or the Foundation 1 assay. And some other eligibility criteria were that they were allowed the prior therapies as it is expected in the normal real life setting, that since these patients are in an advanced stage of cancer, lung cancer, they must have some prior systemic therapies like some platinum based chemotherapy drug or even some immunotherapy drugs. So they were all allowed in this clinical trial. But there is one condition, I will mention that in the next slide, but overall they were allowed in this clinical trial. Another thing is the patients must have adequate organ function. That is to ensure, firstly, the drug does reach the target site. Since it is an oral drug, it must get absorbed from GIT into the systemic circulation, but after that it must reach its target site in the lungs. So if the heart is pumping enough blood, only then it can reach effectively to its target site and be efficacious. And another thing to related to adequate function, organ function, is the drug must be cleared by kidney afterwards. Otherwise, it can cause safety concerns. So that's why the patients must have adequate organ function to be participate in this clinical trial. Now, some exclusion criteria were also there. I mentioned that patients who had systemic therapy prior were allowed, but there was one condition, that the therapy must have been stopped 14 days prior of taking the first dose of Poziotinib. And another thing related to the organ function, again, the cardiac ejection fraction should be at least 50%. That is again to make sure that the drug does reach its target site effectively. And patients with CNS metastasis were allowed, but they should not be symptomatic. All the symptomatic patients with CNS metastasis were excluded, but those who do have CNS metastasis on CT or PT scans, PET scans, but they're not showing any symptoms, they were allowed to participate. Moving on to the intervention, totally there were 30 patients, and all of them they received Poziotinib once daily, and the dosage was 16 milligram. The treatment it was continued until progression or intolerable toxicity was encountered. The treatment, they were allowed to continue this Poziotinib if they observed some sort of benefit, even after the completion of the initial planned period for this clinical trial. And this decision was left up to the local healthcare provider, whoever was in charge of the patient and providing them uh, health services. They were given an option to continue this Poziotinib if they found it to be effective for the patient. In case of the adverse events, it was allowed to reduce the dose. For the level 1 adverse events, the dose could be reduced up to 12 mg per day, and for the level 2 adverse effects, it could be reduced to 8 mg per day. And after that, if the toxicity still did not go away, they were allowed to discontinue the therapy. Moving on to the outcome assessment within the methodology, the tumor was assessed by the CT scan, computed tomography, or the positron emission tomography every 8 weeks. The primary outcome was the objective response, either partial or complete, by the RECIST. So, objective response rate, or OR in short. Safety was also monitored. In the secondary endpoints or the secondary outcomes, things that were looked at were progression-free survival, duration of response, disease control, and overall survival. These are some of the metrics that are frequently looked at in the cancer clinical trials. The progression-free survival is basically the time during which the disease does not progress from taking the first dose of the therapy. In this case, it is Poziotinib, to the detection of any growing disease. The duration of response, the time from first documented response to progression, and the disease control is the percentage with best overall response, and the overall survival is the time from taking the first dose to death. It does not take into account any progression. It is just from first dose to death by any cause. Moving on to the results, we can see the patient characteristics here. The median age was 60, even though in the criteria they mentioned that anyone over the age of 18 can participate. But the patient population in this non-small cell lung cancer is such that the median age came out to be 60. The majority of the participants were females. They were 22 out of the 30. 5 of these 30 participants had a smoking history, and just like I mentioned earlier, that within non-small cell lung cancer there can be subtypes, and in that the histological adenocarcinoma subtype is the most common one. And in this clinical trial, all of the 30 patients had that histological adenocarcinoma. Most of the patients were also taking platinum-based chemotherapy, and they were also taking some sort of immunotherapy, PD-1 or PD-L1 inhibitors, and about 1/3 of the patients were taking some sort of therapy that was targeted at the mutations in the HER2 gene. In the response, the major objective was the objective response rate that came out to be 27. Now, it's not very significant. Treatments or the therapies that we already have produced about 20 to 21% objective response rate within this patient population having the HER2 mutated non-small cell lung cancer. So it is not very significant, but it is some improvement or some incremental improvement is there. Then confirmed partial response, it is 8%. The stable disease was found in 14% of the patients, progressive disease in 8%. Response rate at 8 weeks was found in 43% of the patients. These patients have to have some response, partial or complete, doesn't matter, but some response was found in at least 43% of the patients. That is encouraging, but it also depends on what is the level of that response. And disease control rate, it was found in 73% of the patients. This is also good, but again, it depends. If we go into further details, the control rate might not be that significant. The major objective, that was the ORR, or the objective response rate, from the results is the 27%, and that is the takeaway stat from this whole table, the 27% ORR. In the secondary outcomes, the duration of response was also measured, and this is the Kaplan-Meier estimate. This is frequently used in the clinical trials, and you can see this is the survival estimate frequently used in clinical trials. With the passage of time, the survival or the duration of response, it is decreasing significantly. The progression-free survival, this is also a secondary outcome, as it is in many cancer-related clinical trials. This is the time from the first dose to progression of the disease. And here again, it is coming down significantly with time. But the PFS 30, or progression-free survival 30, it is at 6 months, but the median is 5.5 months. Then waterfall plot is there. It is representing all of the patients. These are all total 30 bars. The red ones, they are indicating the progressive disease. In all of the patients that the disease progressed, they are represented in the red. The stable disease is in blue, and the confirmed response is in like this greenish colored bars. Two of these patients, they were decided by their primary care providers that they can remain on the therapy, that is the because they found it to be effective. But all the others, they discontinued after the period for the clinical trial ended. And you can see some of them had progressive disease, but most of them had some sort of benefit. Again, this is the swimmers plot showing nearly the same thing. All the 30 participants have their own bars here. And here you can again see the progressive disease. It is in the red color. These are all the progressive diseases. The progressions, first we talk about we should talk about the response first. So the response, it is represented in this orange circle, and the progression, it is occurring after some time. So this might be due to the resistance, because they are showing some response. It is being recorded here, but after that the progression is also there. So the tumor might have acquired resistance after the initial response. That could be one of the reasons for the progression. But they also followed the patients afterwards, and all of the patients that died, they are represented here in this X marks or the cross marks. So a lot of the patients, or the majority of the patients, died, but some were kept on the treatment, and both of these patients are represented here in the top two bars. Then moving on to the safety, and safety is a major concern in this was a major concern in this clinical trial. 97% of the patients experienced some sort of safety-related issue. Most of them were not that severe. They were adverse effects from the grade 1 or 2. The common ones were skin rash, diarrhea, aronica or oral mucositis, and dry skin. Paronychia, it is the inflammation or the infection near the nails in the fingers or toes. This is the infection near the nails. And oral mucositis, this is the inflammation of the oral cavity. Within that, the mucous membranes get inflamed. The severe cases, they were in the grade 3, were also some of these common adverse effects. One patient died because of pneumonitis. This is the inflammation of the lung, and the reason could be related to or caused by the active therapy or the drug being used in this clinical trial. One patient had to discontinue. 16 patients underwent one dosage reduction, and 6 patients underwent 2 dosage reductions. So this is quite significant in terms of the safety, and this does not represent a very encouraging safety profile of this drug. In the result, in the safety, again, you can see all of this information in this table. Some other adverse effects were alopecia and nausea. Others are same as we discussed earlier. Moving on to the discussions, the Poziotinib achieved the primary objective, that was the objective response rate or ORR of 27%. It is uh, more than the previously encountered ones using the already available therapies, but not significantly larger. It does give us some better option into treating these patients, but it is not very significant. And also, we have to consider the safety profile that is not very good for this medication. Also, the other subtypes for HER2 exon, they also had similar results. And the Zenith 20 trial that is based on these findings, that is another clinical trial, it reported the ORR of 28%. So very close to the this trial, and the duration of response was 5.1% in mean. The limitations, as I discussed earlier, the sample size is very small. They are only single center, and only 30 patients are there. And one significant one was the no control arm. That is not giving us very information to compare with. Like if we move for previous slides, if in the Kaplan-Meier plot, if the control was there, that would have given us a better idea, but the control arm was not included in this clinical trial. So this is one of the limitations. And then another one is there was no independent review of this clinical trial. A larger clinical trial is being performed that will address these limitations. So in conclusion, Poziotinib, it did show some benefit for HER2 mutated non-small cell lung cancer. The toxicity was significant, but according to the authors, it was manageable with the dose modifications. And optimal dosing regimen still needs investigation. It is at the phase 2 clinical trial, and still we are talking about the dosage optimization. So this is not a good sign, because at this point the dosage should be known, but perhaps in the larger clinical trial, maybe that can be addressed as well. The impact of this research is, firstly, it adds to the options for treating HER2 mutated non-small cell lung cancers. They do not have a lot of options at this point. And also, in a bigger picture, it is good in a way that it is aiming to target those mutations that are resistant to our targeted therapies. So it is encouraging in that aspect. And further research is needed to focus on targeting these resistant mutations in various types of cancers. Thank you so much.
Thank you, Numal, for this detailed talk. Here are some questions from the audience. Vijay asks, was the positive outcome enriched for patients with prior treatment history?
Actually, all of the patients had, almost all of the patients had the prior therapy. So I cannot infer from the given data. It would have been better if they for this question, to address this one, it could have been better if they had two arms in which one was the patients with the prior therapy and one in which it was given in the neoadjuvant settings. But it was not the case in this clinical trial, so it is difficult to say.
Thank you, Numer, for answering this question. I have one question regarding a general question that has this drug received FDA approval to treat the non-small cell lung cancer, or especially this type of the HER2 exon 20 mutant type of the lung cancer?
It did receive the fast track approval. It cannot receive the approval just yet, because this is just a phase 2 clinical trial, and there must be a phase 3. With 30 patients, we cannot decide. We cannot give the approval, and FDA won't give that approval. But it did receive some encouraging things from FDA, that it was given the fast track. The status of fast track therapy, but the results are not that encouraging, and currently the authors, they are shifting towards targeting the EGFR mutations, because as I mentioned earlier, it is also effective in the exon 20 mutations in EGFR gene. So they're not they're shifting towards the EGFR mutations, but the clinical trial, the larger one that I discussed, it will still be performed, and that might give some more encouraging results, and based on that, it may or may not be approved. But at this time, we cannot say that it can get approval, because this is the phase 2 clinical trial.
Thank you, Numer. Nupur asks how this drug addresses this particular mutation.
They've not given the scientific basis. They have performed the in vivo and in vitro studies before that, and that might give us more information as to what is the biological basis behind the effect. But in this one, in this particular paper, they have not discussed the biological basis.
Thank you, Numer. Hope it clarifies your doubt, Nupur and Vijay. Is there any question from anyone? I think there are no further questions from the audience. So here we come to the end of today's webinar. Thank you for joining us today. I hope this webinar found informative to all of you. And before we wrap up, I would like to give you a quick update on our upcoming webinar. Our next presentation will be on 28 September 2023, and Divya will be delivering a talk on artificial intelligence-based prediction of lung cancer risk using non-imaging electronic medical records deep learning approach. Thank you so much for joining us today. Thank you.